turn the time over to you, Christine.
Good afternoon, everyone. Christine Stewart with Presbyterian Health Plan. Sarah Lopez is my boss, and she is the Behavioral Health Clinical Director with Presbyterian. This is her presentation that I kind of hijacked for this presentation today, so that's why her name is still on there. So the goal of my presentation today is to explain what care coordination is and what police officers, first responders, law enforcement, any type of what we call justice involved at Presbyterian facility would need to know about it. First, I wanted to back up a little bit and just kind of explain the Centennial Care approach within Presbyterian. Has anyone heard of care coordination or is familiar with any of the state initiatives with Centennial Care?
Jeff Bloworth with APD. Maybe it's because I'm so young and I just signed up for health insurance through my employer. What is Centennial Care? Like, what is it exactly?
So Centennial Care is going to be the Medicaid plan within Presbyterian, well, any MCO, really, any managed care organization. The Medicaid plan will be called Centennial Care. There are 3 managed care organizations right now in Albuquerque. There's Presbyterian, or in the state of New Mexico. There's Presbyterian, Blue Cross Blue Shield, and Western Sky Community Care. And we all offer care coordination if you have Centennial Care. And we all are very similar. The big difference would be just the providers that are in network with each of the managed care organizations. This slide shows the approach that Presbyterian Health Plan has. As you can see, that it's a circle with the member at the middle. We have a member-centric approach where we can't help individuals with, let's say, approaching their long-term care needs. They're bedridden and they need a caregiver and other types of services if they have other psychosocial factors in place. A lot of the population that I've worked with as a care coordinator have been homeless, have substance abuse problems, those types of things. It's not going to help the individual if I get them set up with a primary care doctor appointment and maybe some other type of generic medical service if they don't know where they're sleeping that night, if they can't stay clean and sober, and so on and so forth. So the goal that Presbyterian has is to really look at the member as a person and all of the struggles that they're facing and kind of work our way out to have a whole individual be more successful in the long run. So today we're really just going to talk a little bit more about care coordination and what police would need to know about this program, just so that you kind of leave feeling like this could be another tool that's in your pocket when you're out there in the community. There's a note on here that we take referrals for any person who's on Medicaid who is voluntarily interested in the program. That's one of the caveats with Centennial Care is care coordination is an added benefit for them, but it's not anything that's mandatory. So just because you have Medicaid, you have Presbyterian, if Presbyterian calls you and offers care coordination, you can decline it. We try to encourage people to engage in care coordination, and we really present it as something that can benefit them and meet them where they're at. That's how I, as a care coordinator, when I was carrying my caseload and doing that, approached everybody. Where are you at? What can we work on? How can I help you? Because it's going to range based on the individual. We're there to identify anything and everything that we can offer them, but that can be extremely overwhelming if they're in really poor health. So we just kind of try to tackle things one by one. Care coordination is really kind of what Centennial Care is based around. Centennial Care is obviously the Medicaid health plan, so there's going to be benefits and customer service and all these other things that you expect with health insurance, but care coordination is really the heart and the people that are trying to drive the movement of Centennial Care. What we're ultimately trying to do is promote more independent, healthy, self-sustaining individuals, people that understand preventative care, people that actually engage in preventative care, and people that are better contributors to their community. A lot of people that I've met with have no idea where to begin. They have no idea that they maybe don't even know that they're Presbyterian until we called them because they were just auto-assigned through the Human Services Department. They don't know where to begin. They don't know what benefits that they have. Maybe there was, a disconnect with getting their member handbook. They might not even know how to handle or how to access anything. Everything's so technology driven, and a lot of our members don't even have phones. So us being there to kind of connect them with everything, and I bring my computer if there's anything that I can help them access, that sort of thing. We're really trying to get people to participate in their own healthcare and understanding what's available to them. We also take an approach of really building in a team. We get releases of information for all of the providers and people involved in everyone's care, but we really try to encourage that. If I can talk to your primary care doctor, if we encounter any kind of problem, maybe you don't like your medication, you don't feel heard when you're in the appointments, if I can come with you, if I can reach out to your doctor, we can start bridging those gaps instead of just having people stop services or clump all providers into I hate all doctors, that type of thing. We also have specialty teams, which I think is I'm getting ahead of myself, is on an upcoming slide, but in more complicated cases, maybe a client is a kiddo and they're in treatment or foster care, there's going to be much more people involved in the care and in the child's life, and we really try to be in every meeting and every part of that client's life that we can. We try to link them to services, treatments, also community services and supports. I know that's another thing that people don't know that are out there. Presbyterian has care coordinators that specialize in behavioral health, physical health, and long-term care. So depending on what your primary need is going to be, you're going to get a care coordinator that has worked in that field in some other capacity. A lot of the physical health care coordinators were nurses. A lot of the behavioral health care coordinators were licensed therapists or were community support workers, things along that line. So they're going to know what's out there in the community and how to build a little bit more infrastructure around the individual. Just continuing to address that we're really trying to treat the member as a whole and come at them from all aspects. This slide is just reinforcing that again. We do what's called a health risk assessment to identify people that are high needs. In the next couple of slides, we'll break down how often we do that and how the outreach is targeted. But we're really trying to identify people that need care coordination and picking them up and getting them to engage.
Jeff Leverth with APD. The health assessment, can you explain a little bit like what that is?
Absolutely. So that we have several assessments that we do, but the health assessment is kind of the starting point, and that is going to be general questions as far as what services do you already have, what services do you think that you need, if you even know, what types of supports do you have. We're also trying to pick up on big safety concerns. Are they having immediate symptoms of any kind? Is there any type of safety risk within their home that we should be aware of as a care coordinator going into their home, but also something that we can maybe start to help with on a community level as well. And that's a good point with the health risk assessment that also determines how we refer clients. There's a couple of different ways people can come to us, but one would be if somebody was doing a health risk assessment and was identified as having an immediate need, whatever that may be. It might be a behavioral health immediate need, they're in crisis, they're suicidal, or something more along the lines of a safety concern, maybe something where we want to involve adult protective services, or they're not able to care for themselves. Those people are going to be triaged, so to speak, to get a care coordinator assigned as soon as possible and get them out to the home.
So maybe Jeff Leverth again, with the social aspect, I have Hulu and Netflix. I was hoping I could get HBO Go so I could keep up with the last season. Is that one of the services you guys help out with?
That's a great question. I do encounter quite a bit of requests like that, kind of random things. I myself as a care coordinator would try to be pretty tenacious and pretty creative when it came to things that they needed. Not necessarily more cable options, but things. I had somebody in need of a water heater, and I got them linked to a community health worker because they have within Presbyterian. We also have peer support workers, community health workers. We can also refer out to core service agencies around Albuquerque or any of the other community providers to get them additional case management to kind of build a team. And if I don't know the answer, maybe somebody else will, or maybe somebody will have a little bit more time. We can also pool care coordinators just within Presbyterian. We staff cases all the time in several different types of formats. So if we have a request that is odd, for lack of a better word, or maybe something that we haven't encountered before, we can staff and see if it's a possibility.
Awesome. Well, it looks like we have a question from Brian Carter. So would this be initiated or automatically triggered in the event of an officer taking someone in for a mental health evaluation? And would this include juveniles as well?
Is a mental health evaluation done in the hospital? Is that the process normally?
So we usually take them to like Caseman or 2600 Marble, UNMH.
Okay.
And then from there, they will get evaluated, and then it all depends if they get inpatient or not inpatient.
Perfect. Okay. That's a great question. And I would like to say yes. I don't know if 100% of the time it's automatically being triggered, but I do know that anytime there's kind of big indicators, like if somebody's gone inpatient for any reason, especially for a mental health reason, if somebody is in CYFD custody, they kind of get auto referred to care coordination. They still have the option to decline, so that's going to be kind of the caveat there, but we will receive the referral. We also, at Presbyterian, I don't know if the other managed care organizations do that, have behavioral health care coordinators specially assigned to each of the hospitals. So there's somebody at Caseman, there's somebody at UNM, there's somebody at Haven, there's somebody, I think, at Presbyterian Maine, maybe just kind of hanging out there. They are for sure at all of the psych hospitals, as well as some of the big ones around the state as well. So we are trying to capture people when they're inpatient, live time, to reduce the crisis, reduce recidivism of returning to inpatient. That's a huge initiative right now. And we have a full specialty team with a special supervisor designated to that program.
I'm Corey Barger. I'm one of the psychiatry residents from the University of New Mexico. For us, if it would be an adult coming into the PES, the Psychiatric Emergency Services, that would not automatically trigger this from what I've seen observed. If they go to the inpatient unit where they're working individually with social workers, that's where they would more likely be referred to this, plugged into this if it was an option for them. All of our children cases, so for juveniles, them coming in, it wouldn't trigger it automatically. All those cases, as of a month ago, I know once the child came in, the case would be reviewed by some of the child fellows and followed up. And I don't know if they would have the ability to put this in, but from my understanding right now, just being brought to the psychiatric emergency service would not trigger this. It'd take an admission or something else for the social workers to specifically become engaged.
Right. That's a really great point, that there's no automated system for, as far as like UNM's hospital system wouldn't communicate with like Presbyterian customer service to generate a referral. A lot of times it's individuals like social workers or anybody else generating the referral. It can come from anyone. So if there was somebody that you yourself were concerned about and maybe had 5 or 10 minutes to call, you can call Presbyterian customer service and generate the referral. And it's if you have the person there and they're ready to do the full health risk assessment, you can actually dive into that. It takes about 15 minutes. But if it's more of just kind of saying, I have this person, I'm really worried about them, they're now at UNMH, I think they're in this department or this room and I have this contact number, then we'll kind of take it from there and track them down. And we'll get that referral. And I will leave, or I have handouts and things I will leave here, but then I also will get all of the information out electronically as far as who to contact in the case that you were interested in generating one of these referrals.
And then just the second part of that question from Brian Carter, does this, you kind of addressed it a little bit, but maybe I just missed it. Does it include juveniles? Like does Presbyterian do care management, case management for juveniles?
Yes, yes. We have care coordinators that have babies on their caseloads. Usually that's going to be kind of like specialty maternal child, teens and things, but anybody from the age of 1 month old to 99 years old or plus can be enrolled in care coordination, and then they will just be assigned based on their needs. So whatever the specialty needs are of the individual. Once they hit the age of 14, then they themselves have the option to decline. So if mom wants them in care coordination, they're 16, they don't want to be in care coordination, they have that right, but we still try to kind of work with them and show them what the benefits are. Depending on the situation, I don't have a lot of refusals. Usually if I do, it's appropriate in a way. They are kind of established with all their healthcare needs. And sometimes it's not. Sometimes they just absolutely do not want the help. So, but as far as juveniles go, they're usually pretty compliant with whatever parents or CFD or that sort of thing want them to do. And kind of going along with what I was just saying, we really focus on a relationship building model. I can come in there with the client and come with my agenda of all the things that I need to get done, all the data that I need to capture to provide back to the state, all the things I need to be put into the computer. But that isn't going to help the individual, and that's also probably going to shut them off from like, what are you doing here to help me? So we really go in and just try to have a conversation with the individual and what they need and understanding what their struggles are. And I know when I'm speaking with somebody, I'm going through the assessment, but in a discussion format. And as they're speaking to me, things will pop up that will trigger, that's a benefit, or have you had your eyes checked, that type of thing. Or I wonder if these two things are related. Have you ever thought of that? Has anyone ever told you that? You have anxiety and your stomach hurts all the time. Has anybody ever maybe talked to you about those being related? Or have you ever thought about seeing a specialist because you have the ability to do that, and this is how you do it? Like I was talking about earlier, when you come in and do the assessment that we use after the health risk assessment, that is the initial assessment to trigger if they need care coordination, for safety alerts, that types of thing. Then we go in with what's called a comprehensive needs assessment, which is a very thorough assessment to go in and out of all of the preventative care things, primary care, dentist, eye doctor, specialty things, cardiac symptoms, GI symptoms, behavioral health symptoms, depression inventories, all these things. And then it will generate we call them opportunities, every opportunity that this person could benefit from. That can be extremely overwhelming if you're in poor health and you basically need to do everything. Get your eyes checked, get your teeth checked, see a primary care doctor, get 3 different specialty referrals, start counseling, get a case manager, and you're homeless. So we are really there to focus on building the relationship, giving them some goals to start working on together, and then kind of keeping everything else organized for them. We'll pull in more goals as we go ahead. Maybe we focus on homelessness and just getting you a physical first. Then we pull in case management or something along that line, and down the line we get your eyes checked and that sort of thing. And how first responders can use this program. We were talking about this just briefly earlier, but basically anybody can access this program if they call customer service, and the phone number is not up there, but I should have put that up there. But it's, I'll send it out to everybody. It's also, if you just want to jot it down, it's 505-923-5200. and that will send you to the customer service here in Albuquerque at the Cooper Center Presbyterian. And they will walk you through the process. And like I said, if you have somebody there and they're engaged and they're ready to do the assessment, they can see that through, or you can just kind of pass along your concern, and then we will pick it up and try to engage the person moving forward. Also, if they already have a care coordinator and you are aware of this somehow, and maybe that person can give you their phone number, then you can call. I've had that happen before when I was a care coordinator, but then I would get a call that maybe there was a situation that my member was involved in and they were evicted from their house or something along, I can't think of the exact, it was like several years ago, but something along those lines. And then that really mutually benefits me to know now we have an immediate need that was not there the last time I spoke with this person, and I can go out and kind of follow up and help get them connected with the resources that they need.
Jeff Bloodworth with APD. If I call and I have like a name of John Doe, would they be able to look in the database to see if they already have a case manager?
Yes, that's a great question as well. If you weren't aware and you're like, they might, I don't even know if they have Medicaid, they might have a care coordinator, then they should be able to look that person up for you and get you connected. I've received calls from customer service to my phone when a member's lost my card, or when someone's trying to reach me that doesn't exactly know who I am, and then I've gotten patched through from customer service directly to me and been able to get that message passed along. We also have a website. It's just phs.org, and we can do a lot of stuff electronically through the website, including requesting care coordination, submitting appeals and grievances, that type of thing. Like I was talking about earlier, a lot of our members don't necessarily have computers or maybe don't even have phones, but that is something. I always bring my computer with me, and I try to show people how to use the portal to track their own health records, how to use some of the tools that are out there on the website. It is very user-friendly if they do have computer access. And Medicaid versus non-Medicaid would just be basically Centennial Care is a Medicaid-only plan. So care coordination is going to be only offered to those with Medicaid. However, if you do not have Medicaid, you have a commercial plan, there's still a lot of support within Presbyterian. There's customer service, we have member advocate teams, we have provider relation teams, and we have crisis numbers, things like that, quit smoking numbers that can still be accessed by non-Medicaid plans. So when a referral comes in, what do we do? So basically our first step is to try to reach out to the individual as soon as possible and conduct the evaluation. We're trying to triage them, levels 1, 2, 3, and if we have a nursing facility level of care are kind of what we're looking at, and we'll get into that in detail in each of the next slides. But basically our biggest concern is getting in contact with that member and letting them know that we're trying to offer them care coordination. For level 1, basically level 1 is somebody that doesn't necessarily need care coordination, but they're still in Centennial Care and they still have Presbyterian. What we will do at Presbyterian is reach out to them and do an annual health assessment. The reason why we're doing it annually is because at any given time you can have a major change of condition in your situation, health-wise, socially, that type of thing. So we're just trying to continually reach out and make sure that nothing has changed. Because I don't know that if something changed in my life, I would think to call my health insurance first. So we're trying to kind of initiate that process. We also have a team of people that will be reviewing claims and utilization management data or the big inpatient stay data to determine if there's been one of those changing conditions. Maybe if there was something, I don't want to say minor, because breaking a bone would not be minor, but if there's something that's more acute that you can get treated for and then you can heal from, that might not warrant a changing condition. But if you were given a new diagnosis of diabetes, and then you've also now started to really struggle with your depression, and you don't know how to manage the diabetes, that is going to be maybe something that you want to bring in a care coordinator for. We also review the hospital and emergency department visits. We try to do them real time. There used to be a huge lag. We wouldn't even be notified of people in the hospital for 3 to 5 days, and now we're notified usually the same day. And we also try to get out there the same day. That's why we built the specialty team, and so that care coordinator only goes to that facility. So most of the time they're actually physically there at that facility. But these people are not assigned a care coordinator. They're just kind of hanging in a queue if they need care coordination. For level 2 and 3, these people are going to have care coordinators assigned to them. They're also Centennial Care members of Presbyterian. These bullet points are just listing out some of the indicators that would kind of trigger the level 2 or level 3. However, you don't have to have one of these to get level 2 or level 3 care coordination. You could just want a care coordinator. You could just want that extra support or somebody there. I know a lot of people on my caseload, even once they were kind of stabilized, they still really liked having Christine from Presbyterian that they could shoot a text message to and not have to call customer service or kind of navigate it that way. So you can have a care coordinator without necessarily needing one of these. And then at the bottom, behavioral health diagnosis, including substance abuse, that adversely affects their life. We have also what we call the health team, and they are care coordinators that primarily will focus on people with substance abuse issues or people that are readmitting to the emergency department frequently and that we kind of can't catch for whatever reason, or that we can't fully engage. So they are actually boots on the ground out in the community at shelters, at emergency rooms, just kind of offering care coordination and trying to kind of spread what care coordination is. I think a lot of people don't even know that it's available to them, despite all of our trying to go to everyone over the phone and get the word out. Some people don't understand it, or maybe they've had a bad experience with it when it first started 5 years ago. It's kind of a rocky start. Stuff's definitely gotten balanced out since then. I think the next slides will go into the differences in the levels. Yes. So level 2 and level 3 is basically just what level of intervention the member might need based on their needs. And then this just outlines what my job would be with that person based on their level as far as my assessments go. They're very similar, but basically level 2 will be every 3 months, level 3 will be every month. Level 2 is going to be somebody that maybe needs some education on preventative care, needs to get linked up with providers, and maybe has a substance abuse problem but is seeing a therapist in recovery. Level 3 might be somebody who's homeless, somebody who's pregnant with a high risk complication, maybe they have a substance abuse problem, or somebody that's just unstable, for lack of a better way of putting it. They really need kind of more consistent support. And these touch points, as we call them, are going to be what we do on the minimum. Most of the time, we're meeting with people more frequently than that. And I always encourage all of my members to reach out to me as much as they need me. So if I've met with you in March and we're not due to meet again until June, don't wait until June if you need something. Please reach out. Let me know what you need, and we can move on from there. Anytime anyone has anything major happen to them, we also encourage them to reach out because these levels can fluctuate. You can be at a level 2, everything's going really well, and then something happens that kind of has a cascading effect, and then they need to actually be increased to a level 3. I had a member that I met with, and initially level 2, everything seemed to be pretty by the book, so to say, like let's get you engaged with some providers and move forward, and then they got kicked out of their home, and but very abruptly. It had to do with like a coding thing with the actual building. So then they were a level 3, and there was much more intensive emergency kind of care coordination that happened in that situation. And now they're back to a level 2 and doing well. So we really kind of try to swoop in when we know, and the more information that can be given to the care coordinator by law enforcement, by hospitals, by the facilities, by the member themselves will benefit us in being able to swoop in like that.
Jeff Bloodworth with APD. How many or like how big is your caseload? When do you guys have a cap for the case?
We do, and that's based off of a state requirement. So we at Presbyterian, we have kind of a mixed model where I would carry both level 2 and level 3 cases, and so that's like a 1:63 ratio is what they've averaged. If you have all level 3, you're supposed to be at 1:50, so you'd cap out at 50, and then level 2 you would cap out at 75. But everyone usually averages about 63. It fluctuates, and then if you're one of the specialty care coordinators, maybe within the hospital, you'd have a much smaller caseload, or maybe not even really a caseload, because you would be doing the immediate kind of crisis discharge planning and handoff to a community care coordinator. So we kind of play around with some of the numbers there, but that's the model.
And then do you guys, I don't want to say get rid of your cases, but do you ever just say like, okay, you don't no longer need us? Or do they just go to a level 1?
Ideally, that's actually the goal, is to really work ourselves out of the job in a way. We're trying to get people up and running on their own so that they feel confident that they wouldn't need us. Like I was speaking to earlier, some people still kind of really like having that security blanket type of thing, or that like easy go-to versus, having to go through things again. I also wouldn't necessarily be able to like kick somebody off my case. Like it's not up to me to determine like you're good, go forth, be a level 1. It would really be up to the individual. So we try to have those conversations frequently. And we really try to be strength-based, especially at Presbyterian. The way that we write out the goals for everybody is very much, let's continue to do this. Let's focus on the strength that you have and moving forward. So when we have those conversations, it's really based on, look at how far you've come, look at all the things that you've done on your own, look at how much I'm really not doing. What do you think about, being on your own, sort of thing. So it does happen, and sometimes people will be like, no, I'm good to stay with you. So, and they haven't changed that necessarily, that we can ever kind of decide for them.
And then one more follow-up with it. So if you guys have a cap, do you guys turn people away, or is there a waiting list? Or do you just hire more people?
Yes. We've been pretty much just hiring more people, or we'll fluctuate with the specialty teams that we have. So if there is kind of an overflow, some of those health care coordinators that I was saying are the boots on the ground, they don't really carry caseloads. Sometimes we'll bring them in, reduce their time on the streets, for lack of a better way of putting it, and give them the caseload. Or we'll just kind of shuffle around duties so that we're not inundating one care coordinator, because then I'm useless too. If I have too many people, I'm not gonna be able to keep up with the paperwork and help everyone. So we'll just kind of do some shuffling and or look at hiring on more people if it's just continuing to be exponentially growing. But there's no waiting list, and there's no turning people away. And this next slide talks a little bit about nursing facility level of care. This is going to be people that require assistance with 2 or more of their activities of daily living. So maybe they can't dress themselves, they can't feed themselves, either mechanically or the process of cooking. Maybe they can't shower. And this can be based on a physical need, or it can be based on a cognitive need. I had a member, actually, we're saying it's Brain Injury Awareness Month, and I actually had a member that had a caregiver in his home because he had a brain injury and couldn't function fully, would forget things, wouldn't remember conversations, wouldn't remember to shower, that type of thing. And that, the nursing facility level of care, we call it the NIFLOC, it's easier to say, is built into the comprehensive needs assessment. It's something that will get triggered in the assessment and kind of automatically be screened for. But if anybody thinks that they would benefit from this and we have missed it at any point, can request it. People can also be referred, with this actually being the primary need for care coordination, because this is how you would tap into the benefit of having a caregiver, looking into assisted living facilities, nursing facilities, adult day hab, that type of thing. It kind of opens up a world of additional benefits, which some people want to have the NIFLOC completed just to see if they can qualify because the benefits are really great. If they get denied, I try to frame it in the sense that that means you're actually really healthy, and that's a really good thing. So let's try to keep you focused on that. And if there's something that they really want from within that benefit, is there a way to access it from within the community?
Jeff Bloworth at ABD. Sorry, I'm asking a lot of questions.
No, I like that.
The activities of daily living, I was thinking automatically Lawrence can't reach high things, and I know he doesn't like to sweep, so I know he has difficulty with those two things. Are those the activities that count?
No. So it's
I was trying to help you, Lawrence.
Is that
Just stare him down.
if that was in combination with something else, then yes, what we're really looking for is the best way to kind of frame it in your mind is if you would not be okay, if somebody can't come in and help you do this and you can't complete this task, are you going to be okay? If you can't feed yourself, if you can't bathe, if you can't move, that type of thing, those are going to be huge indicators. We do break it out into things as small as, like you're saying, very, very specific. And that's kind of why it says the 2 or more, because we're definitely not wanting to rule something out if it seems like, oh, that's not really a big deal, but it's accompanied with something else. And then we go in and really break down what they would need help with, so that, because all of that will turn into minutes that they can have for a caregiver, or points, as you could say, like for getting kind of more services.
I have a question.
Yes.
Would that include assisted living?
Yes. Yes. And they do have to qualify for the NIFLOC, the nursing facility level of care, in order to get the assisted living benefit. But if they were to get it and then if they were to be evaluated and get denied, they can appeal it. That's part of the care coordinator's job, is to walk them through the appeal process. We're here really as advocates for them within the health plan, as well as out in the community and with providers and that type of thing. And I have seen them overturned, because I'm coming in, and I try to be very clear with people when I'm doing the assessment, that I'm coming in and basically taking the information that you're telling me and giving it back to our medical reviewers to determine if you need assistance. And it's human nature when people are like, how are you doing, to say things like fine, or like, no, not really, I'm okay. And that's not the case. You really do need help, and you just kind of need to be brutally honest, even especially when you get into toileting and things like that. It's not always fun for people to admit things or talk about things. But the more that you can make them feel comfortable and encourage them to give you that information, the more likely they are to get the true benefit that they're entitled to.
So to apply for the medical waiver for the assisted living, would you have to find the facility first that would accept you and then apply for the waiver?
That's a great question. So when you get into the assisted living benefit, we have long-term care coordinators that specialize in this, and they'll do the nursing facility level of care assessment, and then they will actually help you. There is, with benefits like that, a little bit more of the onus falls on the client, because we don't want to be like, we found one for you, go here. And they're like, what is this place? And I hate it. We're really wanting them to do a little bit of the research, but if they don't have access to the things that they need, maybe a computer or a phone to even make the calls to figure out where they would like to go, then we have a care coordinator that can kind of help you with that. We just can't select anything for you. And that's with any provider, facility, anything like that, but we do help.
I'm sorry, do all the NCOs care coordinators take that role on to apply themselves? Okay.
Yes, as far as I know, yes. I think we all have very, very similar models. With our, like, what do we contract with the same assisted living facilities as Blue Cross Blue Shield, that type of thing. Thank you. Thank you. And we kind of spoke to this a little bit earlier with the specialty teams that we have. This is something I don't know if the other managed care organizations have. I do know there's a state initiative for transition of care, so people transitioning from jail, from an inpatient facility, all those types of things. I think everyone's building up a transition of care team, but Presbyterian has broken it down into inpatient teams. We have care coordinators assigned to the RTCs and treatment foster cares around the state. Juvenile corrections, I myself was in there for a little while. Now we have another care coordinator in there, and me sometimes. People with severe mental illness, severe emotional disturbances. The high-risk maternal team is the maternal child team that I was talking about before, where a care coordinator will actually take on the mother and her children, and that's as part of her caseload. And then we also have a specialty team for children and adults with autism spectrum disorder. So we have an ABA specialty team. And that's something we really pride ourselves in as being best practice. So we're trying to play with the numbers, and like you were saying earlier, as far as the different, we don't want waiting lists, we don't want anybody past capacity, but it is best practice to also specialize everybody as well, so that you're not getting a care coordinator and you need X, Y, and Z, and they're like, I don't know. You're getting somebody who really understands what's going on in the specific challenges that you would face. And I know with the transition of care, we're building, and I believe all the other MCOs are as well, what we're calling the justice involved teams. And so people that have either experience or some type of interest, or not connection, but they have some sort of knowledge of what is a person is going to be facing when they are trying to reintegrate into the community, and what some of the demands are going to be from maybe probation or parole, and reintegrating, getting a house, that type of thing.
I'm sorry, I have a question. If there's an individual who's been incarcerated for more than 30 days. Does Medicaid go in, the care coordinators, to do an assessment? Let's say they need a higher level of care because an injury occurred while they were incarcerated?
Yes, we are in work groups currently with the state trying to kind of figure out the solution to that, because it's kind of like we have a lot of different people and not all the rules are agreeing. So we can work with an individual even if they're in a facility, in a detention center, let's say, and their Medicaid is still active. And then once it goes suspended, then technically we're supposed to step back because they're not our client, but even though they're like in a holding period, but then we're also trying to step in before they're being released, which then they probably haven't had their Medicaid be reactivated. So we're really trying to kind of come up with a decision rule for everyone to be on the same page as far as what we can do there. That is ultimately the goal. And then I know the state is also reaching out to different counties and different facilities and offering contracts for how to use Medicaid dollars to step in and do stuff if there is an immediate need while they're incarcerated and their Medicaid's lapsed too. Do you have any more questions?
Are there any questions from the network? Thank you, Christine. That was very informative. I had no idea about all of that. And so again, this is only if you have Medicaid though, correct? With Centennial Care?
Correct. And we cannot, if I was to meet with somebody and they had Blue Cross Blue Shield, I'm not going to be like, can't talk to you. I'm going to want to kind of try to link them up, maybe Google the phone number for Blue Cross Blue Shield or whoever their MCO might be, because we are really similar. And in a lot of the work groups that I've been going into that's more related to the Justice Involved initiative, we're all trying to work together on this. And we're not here to encourage anybody to pick us over anybody else. We're all